Good morning, everyone, and thank you for tuning in to our presentation. We are pleased to have been selected to present our program of work this year at CAH. We will be presenting on the current landscape and safer solutions for diabetes care among people with lived experience of homelessness. My name is Dave Campbell. I'm an assistant professor and diabetes specialist at the University of Calgary, and I'm the principal investigator of the work we're presenting. I'm thrilled to be here with two of my colleagues, Sarah and Aisling. First, we'd like to start with a land acknowledgement that we're presenting this work from the city of Calgary, which is a beautiful part of the world situated at the confluence of the Bow and Elbow rivers. As a settler, I've made Calgary my home and have greatly appreciated the opportunities afforded by living here. However, long before my ancestors arrived here in Alberta from Scotland in 1905, this land was a traditional gathering place for First Nations peoples. It is the traditional territory of the people of the Treaty 7 region in southern Alberta. This includes the Siksika, Piikani, and Kainai, collectively known as the Blackfoot Confederacy, the Stoney Nakoda First Nations, comprised of the Chiniki, Bearspaw, and Wesley First Nations, and the Tsuut'ina First Nation. The city of Calgary is also homeland to the historic Northwest Métis and to Métis Nation of Alberta, Region 3. We acknowledge all Indigenous peoples who have made Calgary their home. We would like to acknowledge the survivance these groups have shown, despite the hardships they have endured, including harms that have been caused by healthcare and research. It will be important to keep this in mind today as we come together to move forward in the spirit of reconciliation and respectful collaboration dedicated to ending conditions that contribute to and perpetuate homelessness and diabetes. I would like to acknowledge the contributions from a variety of members of my team, past and present, as well as collaborators from the University of Toronto and Calgary, Corey and Sarah from our broader nephrology research team here at the University of Calgary, and the Clients with Diabetes Action Committee, which we will introduce later. We'll begin this presentation by telling you about some of the background and current knowledge about diabetes and homelessness. I will then present some brand new findings using a novel approach to administrative health data. Aisling will then describe the barriers to diabetes care and self-management for people with lived experience of homelessness. And finally, Sarah will tell you about a project that we're launching to address some of these barriers. And finally, how this body of research can contribute to ending homelessness. By the end of our presentation, we hope that you'll be able to describe the current state of diabetes care among people with lived experience of homelessness, why diabetes care for this population needs a novel approach, a safer solution to diabetes care, and how this body of research informs our collective efforts to end homelessness. A 2015 study from the United States found that while the overall prevalence of diabetes among those experiencing homelessness is roughly the same as in the general population, around 8%, the prevalence seemed to be increasing at a faster rate among people with lived experience of homelessness. However, their data ended nearly 10 years ago, with the lines diverging significantly at that point. This was corroborated by a brand new study that was just presented, including data from a number of countries, which estimated that nearly 1 in 4 people experiencing homelessness has diabetes, nearly 3 times the prevalence as in the general population, meaning that in this population, diabetes is a significant comorbidity and contributor to adverse outcomes. A seminal study published in 2000 by Stephen Wong demonstrated that in the black dots, that in the general population, the majority of individuals living with diabetes had reasonable blood sugar control with A1C levels below 8. However, in the white bars, you can see much different distribution among individuals who are homeless, with a much higher prevalence of elevated blood glucose levels in that group. This likely reflects the fact that individuals experiencing homelessness face many barriers to the optimal management of their diabetes. This is demonstrated in a study that we recently published where we found 43 discrete barriers to diabetes management among people experiencing homelessness. Using a methodology called concept mapping, our participants, comprised of both healthcare providers and people with lived experience of homelessness and diabetes, grouped these barriers into 9 discrete categories as described here, including challenges in getting healthy food, inadequate income, difficulty navigating services, not having a place of your own, relationships with professionals, diabetes education, emotional well-being, competing priorities, and weather-related issues. We then asked each participant to rate these 43 different barriers on a 5-point scale of how impactful they are on diabetes management. When we did so, we found that there were interesting differences between how providers and clients rated these different barriers, seen here as the lines which cross in the middle. In particular, noting that clients rated that challenges to getting healthy food was the most impactful barrier, while providers noted that competing priorities were the most impactful barriers, with challenges to healthy food coming much lower. This study showed that challenges to getting healthy food was one of the most impactful barriers, particularly for clients, but that many different barriers contributed to the likely high blood sugar levels that have been documented in this population. Based on the concept mapping exercise, our community-based co-researchers, the Clients with Diabetes Action Committee, undertook a project using photo voice methodology. They took photos that demonstrated the challenges of managing diabetes while experiencing homelessness, and then wrote their stories about the photos they took. Their photos and stories were shared in a photo exhibit, which was displayed in many locations across the country, including at the 2019 CAH conference in Edmonton, for those of you who were there. If you want to read more about this, we recently published these findings in the Canadian Medical Association Journal. This is one of our photos from a co-researcher named Dwayne. He took this photo of the sign outside his primary care clinic. He wrote about how important it was for him to have all of his supports and providers in one location. He said, "If it was not for my medical team and pharmacy working with me on a daily basis, then I would surely be dead. I am so grateful for these supports: family doctor, pharmacist, specialist, cardiac services, physiotherapy, all under one roof. Support is crucial." This figure, also from Dr. Wong, shows that in Ontario, individuals experiencing homelessness utilize far more healthcare resources for acute care than those who are housed. However, despite greater needs, their use of ambulatory care services is much more similar to housed individuals, likely reflecting challenges in access and referral patterns in this population. While diabetes and homelessness has been studied for about 20 years, much of the published literature either uses qualitative methodologies or relies on small cohorts, which don't truly reflect the entirety of the population. Administrative data is often used in health research to study chronic diseases like diabetes. However, these studies haven't been possible in the homeless population, as we couldn't identify people experiencing homelessness in the administrative data, limiting our understanding of the scope of the problem. The first study we want to tell you about today is one that overcomes some of these prior limitations in the health research data for people experiencing homelessness. Our objective was to define the impact of homelessness on diabetes-relevant outcomes, and today I will be presenting the first of those, which is the mortality outcomes. By using a novel administrative definition of homelessness, first validated in 2019 by these authors, which uses coded health information from hospital records. The preferred definition was based on the ICD-10 code of Z59 in the health record. While poorly sensitive, with a sensitivity of only about 18%, meaning it only captures about 1 in 5 people who is homeless at the time of a hospital encounter, it is highly specific, meaning that it effectively rules out people who are not homeless. While it is certainly not a perfect administrative definition, it is better than anything we'd had to use prior. Using this definition, we were able to match people who were homeless at the time of their encounter with people who had similar characteristics but who were not experiencing homelessness at the time of their encounter. In total, we ended up with 5,219 matched pairs of people living with diabetes, using a propensity score match, including these variables here, to address for the potential of confounding. These density plots illustrate the success of our matching procedure by showing how different the homeless and non-homeless cohorts were prior to the match, and then how the curves are overlaid upon one another after the match, meaning that they are a much more appropriate comparison. When these cohorts were followed longitudinally for the outcome of mortality, we see that within 2 years, the survival curves begin to diverge, with a much more rapid rate of death among those who were homeless at the time of their encounter. By 10 years, we can see that nearly half of those who were homeless had died, but only 30% of those who were not homeless had died. This corresponds to a statistically significant hazard ratio of 1.45. Taking a slightly more specific outcome, by limiting to those who died of cardiovascular or diabetes-related causes, we see that the lines take longer to diverge, but eventually they do. And again, the hazard ratio is a statistically significant, but slightly reduced 1.29. Thanks to this new algorithm, these results are some of the first population-based data that we have on the topic, demonstrating more conclusively than any previous study that homelessness is a major risk factor for severe adverse diabetes-related outcomes, as indicated by premature mortality. I will now turn it over to Aisling, who will describe more about the barriers that likely explain why we have seen this finding with respect to mortality and blood glucose levels.
Hi, my name is Aisling, and I'll be talking about our second project, for which the aim was to describe barriers to diabetes care and self-management faced by people with lived experience of homelessness. This project has two different components. There's an environmental scan and a community-based participatory research project. First, we did the environmental scan to identify novel models of care that were being used to serve people with diabetes who were experiencing homelessness. We conducted open-ended interviews with 96 health and social care providers from 5 Canadian cities: Calgary, Edmonton, Vancouver, Toronto, and Ottawa. These care providers worked in 4 different areas of care. They were diabetes care professionals focused specifically on homeless or inner-city populations, diabetes care professionals not focused on homeless or inner-city populations, other healthcare providers focused on homeless or inner-city populations, and other professionals like frontline shelter staff, managers, or social workers. Currently, we're doing a community-based participatory research, or CBPR project, with people who have diabetes and lived experience of homelessness from within the last 10 years. What makes CBPR different from other types of research is that the participants are part of the community that we're trying to help, and they act as co-researchers, which means they're involved in the entire research process, right from developing the research question to disseminating the findings. So to supplement the findings from the environmental scan, we interviewed 8 individuals with lived experience, some of whom are still involved with this project as co-researchers, and we asked them about their experiences of managing their diabetes while they were unstably housed. And I'll be talking about the findings from both of these projects together in the next few slides. Diabetes is a complex condition, and there are many different aspects of diabetes management, some of which are shown here in the columns along the top of the screen. But there are also many aspects of homelessness as well that can pose challenges in people's daily lives, and some of those factors are shown in the rows along the left side of the screen. There are 6 columns and 9 rows here, but realistically there could be more of each. And I know you can't really read anything that's in this table, but that's okay. We just wanted to show you that when these 2 sets of factors interact, you get all the boxes within this matrix. And they represent all the specific types of barriers that people who are experiencing homelessness have to face to manage their diabetes. As you can see, nearly every box in this matrix is filled with specific barriers, and while there are too many for us to discuss all of them in this presentation, we do want to show you one example. So in the first row here, we can see how people may have experienced stigma or trauma while interacting with healthcare providers in the past, and the fear of having that same experience again can impact their attendance at diabetes education sessions. People may also have experienced stigma because of their medication or food insecurity as well. If you're interested in reading more about the barriers from this matrix, we've included a PDF of these slides, and at the very end of that PDF, we have some additional slides that list each of these barriers, so you can take a look at those, but I will be summarizing all of them for you in the next few slides. Healthy food is more expensive than unhealthy food, and people have to use their paychecks to meet all of their other basic needs as well, like paying rent, so sometimes they just run out of money before they're able to buy healthy food. If they have benefits, they're often insufficient to help meet all of their needs, so they have to pick and choose which needs they're going to meet. And there may be programs or services designed to help people access healthy food, but they don't really work for this population. So, for example, meal delivery programs can't access shelters or rooming houses. Sometimes people may intentionally choose to eat unhealthy foods because they're using comfort foods to cope with stressful circumstances. And they might also have cravings for unhealthy food because of the medication or substances that they're using. Some people don't eat healthy food because they're just not used to it, and they don't know how to cook it or prepare it or have any of the tools or utensils they would need to do that. Many people who are experiencing homelessness don't really have the resources to engage in physical activity. So they might not have the appropriate footwear, clothing, or equipment, and they may not have any recreational facilities nearby either. And even if they do have recreational facilities nearby, there are usually costs associated with using them. There may be programs that provide access to these facilities at a reduced cost or at no cost, but usually those require some extra steps like filling out a lot of paperwork, and that can take a lot of time and effort. Some people with diabetes need to test their blood sugars multiple times each day, so they go through a lot of testing strips. Testing strips can be expensive, especially if there's no coverage for them, so many people may feel the need to ration them and use them less frequently than they should. In some shelters, they may not be allowed to keep their testing supplies in their rooms, and that can be really frustrating for people if they keep having to go back to the staff to ask for their testing supplies every time they need to check their blood sugars. Supplies can also be lost or left behind when people move from one place to another, and they can be stolen from communal living spaces if there are no secure storage options. Testing supplies are not covered by some insurance plans or government programs, and often if there is some sort of coverage, it's usually insufficient to cover all of the necessary supplies. And if, for example, supplies are lost or stolen, the replacement supplies are usually not covered, and people have to pay for those on their own. For many people, without some sort of supplemental insurance or benefits, medications are completely unaffordable. And sometimes, even with insurance, the co-pays or deductibles can be a real burden. And even getting insurance itself can be challenging because the benefits and eligibility criteria of government programs are frequently changing, and it can be difficult to navigate those criteria and figure out what's covered, what the co-pays are, what the deductibles are, and so on. One of the barriers to actually taking medication, though, is the fear of lows. Both patients and providers have this fear of hypoglycemia or low blood sugar levels, so they tend to aim to be on the higher side. Having blood sugar levels that are too high can be dangerous, but for people who are experiencing homelessness, it's actually the lows that can be especially dangerous because of the resulting behavior. One of our co-researchers from the CBPR project told us once that he wants to get a t-shirt made that says, "I'm not drunk, I'm diabetic." And as he told us this, he recalled an incident that he had witnessed at a shelter where the staff were removing a gentleman because they thought he was drunk when he was actually just in diabetic shock. This just goes to show that even among people who work very closely with this population, there can still be a lot of stigma and a lot of assumptions being made about people. Different types of substances can increase or decrease blood sugar levels, and they can have an impact on the way that your medication works. Physicians and patients don't always openly communicate about substance use, so physicians may not be prescribing correctly, and they may have a tough time trying to explain to patients why they should be taking prescribed medications when substances seem to have a more immediate and tangible benefit. Some people may use substances in addition to prescribed medication to deal with the side effects of diabetes, like the pain from diabetic neuropathy. Plus, some medications that are prescribed for mental illnesses can actually lead to metabolic syndrome, which can increase the risk for developing diabetes. And these medications may be commonly used among this population. In shelters, residents may not be allowed to keep their medications in their rooms, and they can be lost or stolen. This is similar to the situation with the testing supplies, but with medications and insulin in particular, there's this additional challenge of finding a way to keep the insulin refrigerated. Insulin adjustment and self-administration are complicated processes, and they require an advanced understanding of diabetes. And it can be difficult for people to medicate appropriately when they're not eating regular meals because of food insecurity. In theory, one of the easiest ways to get information or assistance with medications is by going to the pharmacy, but there are challenges associated with getting to pharmacies as well. For one, people may not have a car. and even if they do, parking can be really expensive. Some pharmacies may not be accessible by public transit, and there's this really bad combination that can result with diabetic feet, inclement weather, and inappropriate footwear, and that should be avoided, and not to mention the time that it takes to get there and back. Many mainstream diabetes education programs have a format that doesn't really work for this population. The sessions are long, which can be an issue for people who need to be certain places at certain times, like at shelters or community kitchens for meal times. They can also be intensive, which can be overwhelming for people because it's a lot of new information, and people may be afraid of being judged in a group setting. Even if the sessions aren't intense, there may not be enough time to cover everything that people need or want to know about diabetes, and additional sessions may not be covered by insurance providers or government programs, so people are either missing out on important information or they're having to pay for it. Additionally, in some provinces, attendance at diabetes education sessions is mandatory for people to receive free testing supplies. And while it's great that they have an opportunity to receive free testing supplies, it's not ideal that they have to attend these education sessions to receive them. The recommendations provided in some diabetes education sessions may not be relevant to people who are experiencing homelessness either. So for instance, it may be unrealistic to expect people to follow certain dietary advice when they're relying on free meals and food banks because they have absolutely no control over the food they eat. Cognitive issues like those caused by traumatic brain injuries or fetal alcohol spectrum disorder are also common among this population, and they can also pose learning challenges. As I mentioned that there can be difficulties with physically accessing pharmacies, those same challenges apply to clinics as well. But unlike pharmacies, where most services are provided on a walk-in basis, the majority of healthcare services require appointments. For individuals who have anxiety or paranoia, making appointments and dealing with wait times can be especially challenging. And for some individuals, they may delay seeking care because they're worried about the diagnosis or prognosis of their condition, while others may disengage because they're underestimating the seriousness of their diabetes. Some people might not have a reliable phone connection, so providers sometimes have a hard time reaching them. Sometimes people face penalties, or they may be dropped from a clinic roster for missing appointments, and so they can't go back to that clinic. And others may find the environment to be too posh or intimidating, and so they avoid it as well. Some people may have had negative experiences of stigma, trauma, institutionalization, racism, or other forms of discrimination in the past when accessing healthcare services, and as a result, they may not trust healthcare providers in general. This is an important consideration when making referrals to different care providers because the clients will require some time to familiarize themselves with the new people and the new environment. And finally, as with many other aspects of diabetes management, not having insurance can be a big issue. Many services that are necessary for people who have diabetes, like optometry or podiatry, aren't covered by provincial health insurance. And if they're not covered, then chances are that people who are experiencing homelessness can't afford those services. In addition to the lack of coverage, people sometimes may not have ID or other supporting documents, and that can limit their access to these services as well. So the bureaucratic hoops that people have to jump through are simply just annoying for most other people, but they actually result in insurmountable barriers for people who are experiencing homelessness. And Sarah will talk a little bit more about barriers specific to health services in her section.
Greetings everyone from Calgary. Thank you for having us here, and thank you for tuning into our presentation. Again, my name is Sarah, a research nurse on this team. Thank you, Ashleen and Dr. Campbell, for setting the stage for a project I have become involved in within this program of research. Diabetes is a complicated condition that requires a great deal of effort for people to manage, including working with multiple care providers who can help screen for the onset of diabetes-related complications. Diabetes Canada provides clinical practice guidelines for healthcare providers to follow in providing diabetes-related care. When we talk about evidence-informed practice in healthcare, we are usually referring to practice that follows current clinical practice guidelines. Diabetes Canada recommends a host of regular screens and attempts to slow the progression of unwanted complications. First, they recommend annual screening of the feet for something called neuropathy, or nerve damage that results in loss of protective sensation. This is caused by poor circulation or blood supply, which also happens within diabetes and is the cause of many diabetes-related complications. An example to better explain this would be someone gets a rock stuck in their shoe and they can't feel anything, so they continue to walk on it. The rock eventually damages the protective skin and tissue on their foot. A wound may then develop and potentially get infected without the person even realizing. This is because of the neuropathy, or loss of protective sensation to their foot. If this goes unchecked, devastating outcomes such as amputations can then happen. Secondly, Diabetes Canada recommends annual checks of the eyes to look for something called diabetic retinopathy. This can lead to blindness. This screen is typically done by an optometrist. Third, clinicians are asked to screen the kidneys at least once a year to monitor for complications such as diabetic nephropathy, which is a type of chronic kidney disease. This again is caused by poor circulation or blood supply to the kidneys, which can lead to permanent kidney damage that can then eventually lead to end-stage kidney failure. People with kidney failure are then forced to consider costly life-saving measures such as dialysis and kidney transplants. Clinicians are also asked to monitor blood sugars through a test called glycated hemoglobin, or A1C. This test measures your average blood sugar over the past 3 months. This test is recommended every 3 months to help ensure this number stays at 7 or less, which has an overall effect on reducing the complications I have mentioned already, among others. Managing this number can be done through diet, exercise, and medications, depending on what type of diabetes you have and what the number is. So that was your friendly diabetes education of the day, whether or not you wanted it. To sum it all up, clinicians are asked to screen the eyes, kidneys, and feet once a year and blood sugars every 3 months. If complications are flagged, specialists then get involved. Referrals to specialists can reduce permanent outcomes such as amputations, blindness, and kidney failure. Despite the importance of this regular screening, people experiencing homelessness face significant challenges in completing these tests. One recent study found that less than 30% of people experiencing homelessness met all of the annual screening goals I mentioned. We have discovered that there are many barriers for this population in accessing this important support. When I refer to specialists, I'm talking about many different kinds of feet, eye, kidney, and internal medicine specialists that can support people facing complications. In some earlier work, members of our research team asked service providers what the barriers are, and they had a lot to say. People experiencing homelessness have many competing needs. Some of the more obvious and acute needs include finding safe housing and accessing food. As a result, diabetes management ends up being pushed down the priority list. One family doctor said, "It is so low on the priority list for me to even think about their eyes, to be brutally honest. There's just way too much in the way of structural violence and trauma going on in their lives, in their day, for this to be on the radar." Because many of the outcomes I described earlier may not show up right away and are developed chronically over time, diabetes tends to be easily ignored initially when compared to more urgent needs of finding shelter and food. Another family doctor said, "Diabetes, it's almost like unless you are about to get your leg amputated kind of thing, people are just like, I'm fine." Although this wasn't a surprise, the team also heard there is a lack of trust in this population when accessing health care. Anti-homelessness sentiment and attitudes make for unsafe healthcare spaces and contribute to the structural violence experienced by this population. One family doctor said, "They have the trust relationship with you. Even when they get to a specialist, I find sometimes they don't gain as much ground. I don't know what's going on. I think it comes down to specialists don't have that relationship, which is more important to this population than others." Wait times is a big one, as I am sure all of the listeners today have also experienced. It takes months to see a specialist within our current healthcare system, and lots can change within that waiting time. An administrator said, "As soon as the planning takes place, 2 to 3 months in the future, the chaos of people's lives, for the most part, leads to it being something that they are unable to plan." No-show policies and communication are self-explanatory. Missed appointments are frowned upon, and when you are dependent on others for rides, phones for making appointments, and cannot always get to a phone to reschedule, this all gets really hard, really fast. Barriers involving clinic locations includes optometrist clinics that are typically found in malls and other areas where this population is simply not welcome and are at times asked to leave as soon as they enter. Limited awareness of patient contacts makes it very hard for the education provided by specialists to be meaningful and well received by this group of individuals. And finally, lack of insurance. Although we live within a publicly funded healthcare system, as I'm sure all of you already know, not everything is covered. Examples of expenses paid out of pocket include regular foot care, orthotics, and simply a supportive pair of running shoes, which can go a long way to protect feet when one is on them all day and so dependent on walking as a form of transportation. I found this to be one of the most powerful quotes that I've come across in this work. One dietitian said, "They just can't be bothered coming to be judged that day." This really speaks to the lack of safety currently experienced by so many within our healthcare system today and makes me stop in my tracks as a nurse. Here is a visual our team put together to show how the current healthcare system is fragmented and not flowing as well as it could. At the bottom, our team put together a visual to describe a few potential solutions, with one particular solution, the puzzle piece in blue at the bottom with a yellow circle in the middle. We want to talk to you about this today, embedding specialty care within primary care. While the need for forward-thinking and equitable comprehensive healthcare for people experiencing homelessness is needed, less is known about the process to enact this. This leads us to our current project, a novel point-of-care screening program that brings these specific screening measures, indicated on your screen, to facilities already accessed by this population, and subsequently connects this group to quality subspecialty follow-up support in a way that is people-centric rather than only provider-centric, as we mentioned earlier. We are planning weekly point-of-care screening clinics within an inner-city homeless shelter that people are already accessing. We will eliminate barriers to accessing screening by bringing the screening to them. I get to be the nurse providing the screening in these clinics, and I'm really excited and honored to be a part of this project. We believe this is a safer solution for people that normally feel stigmatized and unwelcome in most places they visit, are hesitant in accessing healthcare, and have limited control on their schedules and ability to get places. Shifting gears now towards a more research focus, for our pilot trial, we will use a mixed methods approach using the RE-AIM framework, first explained by Glasgow and colleagues, to assess our point-of-care screening protocol. The RE-AIM framework prompts researchers to explore the reach, effectiveness, adoption, implementation, and maintenance of program development. Although we will be looking at all aspects of the RE-AIM framework, our primary objective will be to see if our program improves comprehensive screening rates for this particular group of people. We will be using the Equity to Access and Medical Care framework for this project. This framework was recently validated in 2018 by White and colleagues in populations experiencing homelessness. This framework explains that in order for more equitable access, there needs to be supportive health policy, meaning there needs to be a commitment demonstrated through funding and structure from leadership. Secondly, in developing health delivery systems, we want to make sure they are accessible to the people we are looking to support. We also want to make sure there is continuity and the ability to sustain the program. In program development, the population needs to be considered. Developers need to ask, what are the needs and what is the context of people that we're hoping to support? Finally, within this framework, consumer satisfaction is the final goal. We want to make sure patients feel safe and welcome in accessing the healthcare we provide so they come back. This grows trust, and this will be top of mind in how I am planning to govern myself in the care I provide. And once our trial is complete, we will be looking to see if our program enhanced healthcare usage. So in looking a bit deeper into our protocol, we're hoping to recruit 100 to 200 participants. We expect our project to go from the end of this year in 2021 to the end of 2023. Our research design includes a pilot trial, a chart review, and some qualitative interviews. And we're hoping to recruit adults who have any type of diabetes and who are experiencing housing instability. And we're using 3 out of the 4 indicators provided by the Canadian Observatory on Homelessness as our inclusion criteria. The Drop-In Centre has been a major partner in this work. Their research and admin staff, nurses, medical office administrators, pharmacists, and physicians have co-created alongside us many of the pathways to the program developed. I am really proud to be partnering with this facility. I appreciate how they underscore dignity, accountability, and collaborative partnerships in their value statement. The Drop-In Centre offers a broad spectrum of health-related services already. They staff nurses, pharmacists, primary care, and specialist physicians, and when I have gone to visit the facility, it's clear the staff want to be there and are dedicated to the work they do and the people they work with. Primary healthcare, along with a multitude of specialists listed above, can directly and indirectly influence diabetes outcomes. All of these different service providers have the ability to help. But how realistic is it for someone to try and find housing when they are arranging and attending for so many different appointments? Our goal is to bring the expertise of all these different roles to the individual in a patient and context-centered way, tailored to meet their healthcare needs. We've been working with all of these different service providers to make a patient-centric initiative. I wanted to briefly describe our processes and the bedside instruments we have invested in to help us collect all of the required screens. We've spent a lot of time planning with the DI, and we are hoping eventually to get other inner city facilities involved as well, such as the Alex and the Mustard Seed. We will be relying on the facility to recruit and help with scheduling. Ashleen, who you met earlier, will go through consent and through some baseline questionnaires with the participants. I will then work with a few instruments to gather all of the measurements. I will use a Siemens DCA Vantage analyzer to test blood sugars and kidney function through a urine sample. I will test vision, performing a visual acuity test and using the Volk VistaView panoptic ophthalmoscope. I can dilate the eye with a short-acting dilation drop, snap a picture, and send it to a secure database where a retina specialist who is familiar with teleophthalmology will look at the picture, create a report, send it on back to me within a week. I will also perform a foot assessment following the Alberta Health Services diabetic foot screen, along with some basic foot care that I have become certified to do through the Alberta Foot Care Academy. We've established contacts within Calgary for follow-up, and we will report back all of these screening findings to the participants first, also the partnering facility, and Ashleen will interview participants and providers at the end to learn more about their experiences with the trial. So this is a really busy slide, and I don't want to go into too much detail with this, but I wanted you all to see a snapshot of the many pathways we have developed for how we will assign separate risk scores for each area screened. and also how we will respond to the results of each screen. So we've developed pathways specific to each test we do, and we have worked with specific specialists to provide follow-up care. We've also worked with the DI to arrange for assistance in scheduling follow-up appointments, transportation, and we've explored different possibilities for case managers, navigators, or concierge-like support for patients who need to travel to new areas for follow-up. For example, if someone I see has an infected foot ulcer, we have arranged for these participants to be seen that very same day within the Zyvot Limb Preservation Clinic in Calgary, and the drop-in center will help us arrange for their transportation. So how does all of this information help end homelessness, you may ask? We believe there are a number of ways. First, we have already become aware of what the needs are for this specific population, and we will continue to grow in our understanding of this. We believe people experiencing homelessness will have improved access to primary and preventative health care, which may lead to improved healthcare experiences, support, and partnerships, which will also lead to increased health literacy. We know that better support and literacy also helps with improving one's ability to live well with their diabetes. And most directly, we believe we can alleviate some of the competing needs and demands placed on this group, which would detract their ability to seek stable housing and employment. Finally, we believe this knowledge generation will have applicability to other chronic illness management among this group. Before I end our session, I want to revisit the learning objectives we laid out for you today. We explained what the current state of diabetes care among people experiencing homelessness is. We talked about the gaps in meaningful and effective care for this population. We laid out a safer solution that we are currently planning for and hoping to implement in the very near future. And we explained how the solution will contribute to our collective efforts to help end homelessness. Thank you all for your interest and attention for the past 45 minutes. Please stand up and stretch for a minute to take care of and appreciate your own circulation as we transition into the discussion.